So, today I would like to discuss about hyperkalemia versus hypokalemia. See, the normal blood potassium level is 3.5 to 5 milliequivalent per liter. Whereas when it comes to hyperkalemia, it is more than 5 to 5.5. Okay, standard textbook says it is more than 5.5 milliequivalent per liter. We see that the patient is having hyperkalemia. What are the most common causes of hyperkalemia? See, hyperkalemia is a medical emergency. If we find it immediately with ECG is the first and basic investigation to be done in a patient suspecting hyperkalemia, or else the patient will end up in severe ventricular fibrillation and cardiac arrest. So hyperkalemia is a medical emergency. The most common cause of hyperkalemia is all acidosis producing condition. Diabetic ketoacidosis, lactic acidosis, metabolic acidosis, renal tubular acidosis type 4. We have type 1, type 2, type 3 and type 4. In that, rest of the renal tubular acidosis is characterized by hypokalemia and metabolic alkalosis, whereas type 4 renal tubular acidosis is associated with hyperkalemia and metabolic acidosis. Okay, rest are hypokalemia and metabolic alkalosis. Type 4 renal tubular acidosis is metabolic acidosis with hyperkalemia. So these are the causes. Then primary or secondary hypoaldosteronism. Okay, because here there will be impaired potassium excretion into the urine, so there will be more potassium retention in the body leading to hyperkalemia, or because of potassium sparing diuretics, okay, or drugs like AC inhibitors. Okay, so these are the various causes of hyperkalemia. As far as clinical features are concerned, remember children, the hyperkalemia and hypokalemia has a similar clinical features, that is malaise, muscle weakness. Okay, finally there will be respiratory paralysis and death. There will be hypoventilation. So these features are similar in hypokalemia and hyperkalemia. That is why ECG is the first thing we have to do when we suspect a case of hyperkalemia or hypokalemia, because only the ECG findings, we can't even rely for lab findings, because both hypokalemia as well as hyperkalemia, both are medical emergencies. First and the best test is ECG. In ECG, the earliest feature is tall peaked T waves. Followed by that, there will be prolonged PR interval, there will be absent P wave, there will be increased QRS duration, and finally the patient will start showing so-called as ventricular fibrillation pattern, okay, or ventricular asystole, okay, in ECG. Coming to the treatment, what are the three magic drugs we use? Number one is, okay, calcium gluconate, 10 ml of 10% calcium gluconate over 10 minutes. This is the magic drug to treating hyperkalemia. Remember, the mechanism of action of calcium gluconate, it is not going to reduce the potassium level, but it is going to sensitize the myocardium, because hyperkalemia is associated with ventricular fibrillation. So to sensitize the myocardium, we will first give calcium gluconate. After that, we will give insulin. Okay, insulin has to be combined with glucose, so that because of insulin, the patient should not get hypoglycemia. So always combine insulin with glucose. And next, we have to give salbutamol nebulization. So salbutamol nebulization, insulin with glucose, and the first drug is 10 ml of 10% calcium gluconate over 10 minutes. So these are the three important magic drugs used in the treatment of hyperkalemia. Unless and until the patient is having severe metabolic acidosis, don't use sodium bicarbonate. Okay, recent guidelines show that there is no role of sodium bicarbonate in the treatment of hyperkalemia unless and until there is severe metabolic acidosis. Coming to hypokalemia, the causes are because of a decreased intake in the diet. Opposite of hyperkalemia, there we say metabolic acidosis is the cause. Here it is metabolic alkalosis is one of the cause. Insulin, beta 2 agonist, alpha antagonist, okay, all those causes hypokalemia, okay, or because of diuretics. Even diuretics causes of hypokalemia. For example, loop diuretics, thiazide diuretics, they causes what? Increased potassium excretion in the urine. Or there we study it is hypoaldosteronism. Here it is primary and secondary hyperaldosteronism, Cushing syndrome, Bartter syndrome, Gittelman syndrome. Okay, all those are associated with hypokalemia. And even drugs like amphotericin B, liposomal amphotericin B is also known to cause hypokalemia. Okay, so decreased intake, hyperaldosteronism, primary or secondary, drugs like diuretics, loop diuretics and thiazide diuretics. Remember, AC inhibitors, no, and potassium sparing diuretics, they causes hyperkalemia. Here the loop diuretics and thiazide diuretics, they causes hypokalemia. Okay, and coming to the clinical features, of course there will be muscle weakness, there will be fatigue, there will be myalgia, okay, there will be respiratory paralysis, and there will be hypoventilation. But here again, ECG plays the most important role. The first and the best test in diagnosing hypokalemia and treating hypokalemia is also ECG. The first characteristic thing in hyperkalemia, what is the first finding? It is tall peaked T waves. Here it is flattening of the T wave and with a prominent U wave. Okay, there will be flattened T wave with a prominent U wave, and there will be prolonged QT interval, prolonged QR interval, and finally the patient may get an episode of ventricular arrhythmias. What is the characteristic or the drug of choice in case of hypokalemia? To give potassium supplementation, slow IV. Okay, because when we give fast IV, what will happen? The potassium levels in the blood will shoot up. Again, the patient will end up in ventricular fibrillation. So the key takeaway message of this session is, whether it is hypokalemia or hyperkalemia, heart is the first organ to be affected. So ECG is the first and best drug. Either the causes, when it says to causes, acidosis causes hyperkalemia, alkalosis causes hypokalemia. Hypoaldosteronism, primary or secondary, causes hyperkalemia. Hyperaldosteronism, then Liddle syndrome, Bartter syndrome, Gittleman syndrome. Okay, diuretics like loop diuretics and diuretics causes hypokalemia. Whereas AC inhibitors and the potassium sparing diuretics causes hyperkalemia. Okay, so these are the important causes of hypokalemia and hyperkalemia. Either in Viva or a short note in your university exam, I am expecting this question.